It's just gone 5 o'clock. You're live on The Pulse. A pleasure to have you with us tonight. I'm Kathy Mutlatlana.
Good evening. I'm Stephen Krutter. So glad you're able to join us. A special half-an-hour interview with Professor Salim Abdool Karim, the chair of the COVID-19 Ministerial Advisory Committee. We'll be taking some of your questions that you sent us on Twitter as well. Of course, first two headlines. The last few days have seen fewer new COVID-19 cases during the second wave of the coronavirus.
Comments are being sought on an interim report that's found that some medical aides racially profiled doctors' claims.
Former President Jacob Zuma's state capture walkout case now escalated from the police to the Hawks.
And the ANC intends to suspend Carl Niehaus for accusing Jesse Duarte of undermining his role in the party.
Good evening. Well, it's now been 300 days since the start of the first lockdown last year.
There's encouraging data coming out of the past few days on the number of additional COVID-19 infections after a reintroduction of some of the lockdown regulations. There were an additional 9,000 cases reported in 24 hours.
However, 344 people diagnosed with the virus have passed away. The recovery rate ticking up slightly at 83%. This shows how the number of additional daily infections has tapered off in the last few days.
Of course, Stephen, when we look at this data, we should remember that the scientists aggregated over a 7-day period to see what the real picture might be. So while some of the tapering off of the number certainly is a good indicator, we'd need to wait a little bit longer to get a true feel of the picture.
Well, the major dip from the highs of more than 20,000 daily infections, dipping to under 9,000, to just over 9,000 today. However, as much as we're trying to get the pandemic under control, we should not forget the resultant excess deaths shown here on a provincial basis.
There's been a significant number of deaths over and above expected mortality based on previous years.
In an important development on this today, an interministerial team has now been established to roll out the vaccine when it arrives in South Africa.
The team will be headed by Deputy President David Mabuza. President Cyril Ramaphosa made the announcement during a virtual meeting with the ANC's Progressive Business Forum.
Today, we established an interministerial committee, which will be chaired by the Deputy President. I will chair the first meeting and then set the whole process on the way, so that we can deal with the various aspects of the vaccine distribution. The Deputy President will lead that whole effort.
Scientists agree that the new variant of COVID-19, which is called 501v2, is more transmissible than the previous variant, but is not more deadly.
Also, with vaccines in the pipeline, no tests have been done as yet to determine whether those vaccines will be able to deal with any new variants of the virus.
However, the consensus for the moment seems that it is likely to have an impact. Professor Salim Abdool Karim has been talking to us regularly on the Pulse since the start of the pandemic. He joins us now. Professor, good evening to you. I suppose we need to start with the discussion about the numbers. We've now had 5 days of declining new cases. A few days ago, the number of new cases was at 18,000. It's now at 9,000 last night. When do we start to see and hope that this is a trend?
Yes, very good evening to Kathy and to you, Stephen. It's a great pleasure to be here, and a very good evening to all the viewers. When I look at the data, I like to see a consistent trend for at least 7 days. And the reason for that is that it's heavily influenced by mobility and in the numbers of tests that are being done. And also there are changes during certain days in the week. So as it stands right now, I have to say that the current numbers that we are seeing are really quite reassuring. And they look like they're going in the direction that we've been hoping for, which is a downward trajectory. But before we take that up and make that a definitive statement, I'm just waiting to see how the epidemic curve in Gauteng pans out. Because I've been a bit concerned that the epidemic curve in Gauteng would take off in a more substantive way than it did. And it might be related to the December movement of people. It might be relating to the restrictions that were imposed at the end of December, all taking effect right now. So overall, it looks like good news, but not quite definitive at this point.
Professor Karim, of course, in many people's minds, the quicker we reach the peak of this virus, the quicker we get over it, and therefore life is able to return to some form of normality. Is that actually going to be the case, though?
Unfortunately, this virus is ever present. And even when we are over the peak, we get into a position of low transmission. During periods of low transmission, we still see ongoing deaths and ongoing new cases. More importantly, we also have super spreading events that give us small outbreaks, whether they're in prisons or whether they're in functions that are held. And so we will live with this ever-present threat for at least the next year or two. So we're going to have to maintain our vigilance and ensure we take all the protections, at least for this year, if not beyond.
There's been several developments, of course, around the introduction of vaccine doses to South Africa. Now, the Health Department has said in the last few days that they do expect the first people in South Africa to be vaccinated by the end of the month, or certainly by the 1st of February. That's when the first doses are supposed to come from India. Do you still think we're on track to actually do that?
Oh, I don't know the details of that, because that's all managed by those who are doing the implementing of the vaccine rollout plan. Our task is to ensure that the latest science is available in terms of guiding and supporting the decisions that are made, but the actual programmatic implementation is left to Department of Health officials.
Of course, Professor Karim, one of the concerning things that I felt came out of the briefing that you and your fellow colleagues gave last night is the fact that we're not done with seeing the different variants of COVID-19, and that this disease is able to adapt, and quite frankly that there could be more variants that are discovered in the future. With that in mind, what kind of planning is it going to require from at least government, from epidemiologists like yourself, to inform whatever strategy we may have going forward?
You've touched on, for me, Kathy, what is going to be the most complicated task. And that is, what is our endgame scenario with this virus? As it stands, we're really looking at two pathways going forward. And those two extremes, there are many points in between. I'll spend a few seconds explaining that. So a good progress, or a good potential pathway, let's call it a best case scenario, is that the vaccines work completely or at a high level, that they prevent the virus, the clinical infection, as well as preventing asymptomatic infection. They prevent transmission, and the antibody protection is long lasting, and that it's broad enough to kill any of the new variants that may emerge. So in other words, all we would need to do is to vaccinate the entire world's population at a sufficient level to get herd immunity, and we should be able to bring this virus down to a manageable level. So that's a best case scenario. Even in that scenario, the virus remains with us, because remember, this is a virus that infects animals. It infects cats and dogs and all kinds of animals. So we can always get it from these animals, again in the future. So we will always live with the threat of this coronavirus, at least for the foreseeable future. So that's a best case scenario. What's a worst case scenario? A worst case scenario is where the virus keeps mutating. It escapes the vaccines, and that we have to keep changing the vaccines to keep up with the virus. And that as we change the vaccines and upgrade them and make them broader in the spectrum that they have to cover, then that means we have to re-immunize our population. A bit like what we do with influenza, for example. And that's just, a difficult situation to contemplate, because just think about what a complex worst case scenario that is. Vaccinating South Africa's population with new vaccines in order to protect them against new variants on an ongoing basis. The truth is probably going to be somewhere in between. But we don't yet know what that pathway is, because we understand so little about how these variants are created, how they impact on our immune system, to what extent vaccines will protect us from them, how long-lasting. So vaccine immunity is. So there's so much uncertainty. In the midst of that uncertainty, we have to plan and we have to act. Right now, the action is we've got to make sure we continue our prevention strategies and that we roll out a vaccine as fast as we can. Those two elements form the basis of our strategy into an endgame scenario.
So many different things to look at. Professor, we do have a few tweets that we've taken in anticipation of this conversation, and this comes from Inhlaka. He's asking the question I think many people are asking, which is, we're in the second wave now. As you say, we're waiting for more information before we can say whether or not the second wave has peaked. You're very worried about Gauteng, but she's asking, is there a possibility of a third wave around winter, considering we'll be heading towards the winter months soon, and we know that previous pandemics have also come in waves?
So the key thing that will determine the extent to which and when we will have a third and fourth wave will be influenced by two key things. And that is the level of mobility we have. And winter, of course, reduces that mobility but collects us together in closed spaces. And the second is the extent to which we continue and maintain our prevention measures. The extent to which we get fatigued and we stop being vigilant, that's going to negatively impact on us. And we have to really be very careful of that scenario, because that combination is deadly for us. Not deadly, but it's a bad combination to be in. Based on that, I think we have a reasonable prospect of having a third wave, regardless of how far we are with the vaccine, because in order to prevent a third wave, we would have to have a very substantial level of immunity, both through natural past infection and through vaccines, and both of which have to be effective against any new variant. So you can imagine that in that scenario, we are likely to see a third wave in our winter, and we're likely to see a fourth wave in our next summer, based on what we've experienced so far.
Professor Salim Abdool Karim with us for another 15, maybe 20 minutes. More questions coming for you, sir, in just a moment. Stay with us here on The Blitz.
All right, so you're live on The Pulse. We'll continue our conversation with Professor Salim Abdool Karim. Let's get straight into it then, Prof. The other issue that, of course, is important has been this one around reinfections and how likely it is for one to be reinfected with different strains of COVID-19. Just round up what we know so far about the process of reinfection, and if in fact somebody is likely to suffer more severely from the disease if they're getting it a second time round.
Sure, Kathy. So let's look at what we've learned so far over the last 7 or 8 months. The first thing we've learned is that reinfection is possible. It often gets mixed with a situation where a person's been infected, but the same virus is continuing to be shed, even though it's dead. And so people test positive at 2 time points far apart, thinking it's a reinfection, but it's actually the same virus. So that occurs quite commonly and gets confused with reinfection. So the way we distinguish it is 2 infections at least 90 days apart and 2 different viruses. So that means we have to know what the 2 viruses are. We have seen several cases of reinfection, they occur. Sometimes the second infection is less severe than the first, but there have been occasions, for example, in Nevada, in the Nevada patient, where the second case was more severe than we saw in the first case. In a recent study done in Britain among workers, healthcare workers in the NHS, they followed individuals who had infection in the first wave and who didn't have infection in the first wave. And what they showed was about 44 of the healthcare workers became reinfected. That led, and if you assess that in relation to all of those who'd been exposed previously, they calculated that previous infection offers 86% protection. So if you want to look at having acquired infection, how much does it protect you from getting reinfected? That study suggests that it's about 86% protection, in other words, as good as a vaccine. Now, that study gave us, for the first time, a glimpse of how we can really estimate reinfection rates. And in that study, it gives us some clues about some of the escape mechanisms for reinfection, and those are currently being studied. We can, in total, say that if you've been infected before, you still run a risk of reinfection. So you still have to continue with your prevention measures. That risk is much lower, but not zero. And if you do get reinfected, there's a chance that your second infection may be more or less severe. Both occasions occur, both occurrences occur.
You've said something there, Professor Karim, and that sometimes people aren't being reinfected, but that in fact it's the initial infection that just spans over a 90-day period. What happens in the interim? Is it a case of people feeling better and then suddenly having their cases progress? Because naturally one would think that they've been able to get rid of the virus.
It's actually a very interesting phenomenon. It was described quite early on in South Korea, where they found 123 patients in a cohort who all were just continually shedding virus and found to have virus several weeks after they've recovered. They are totally well. And the virus that they're shedding is dead. They cannot grow. We've never been able to grow that virus. And that virus is often bound to antibodies because the individuals have antibodies and they're perfectly well. They actually several months later might get ill from something else and go and have a test and found to be positive again, but it's the same virus. So that's not a reinfection, it just happens to occur. We don't fully understand why that's occurring, and it's not at this point, it does not look like that's associated with a separate condition we see in about 1 out of 10 patients who get COVID-19, something called long-haul COVID or long COVID. That's where people have long-term symptoms of the immune effects of COVID. This viral shedding is not known to be associated with that at this point.
Sure. So much research still being done at the moment, Professor. I would like to ask, if you don't mind, about, there are so many people, and I'm sure you get stopped in the street and asked questions around Ivermectin. We know that, for example, there are some doctors who are using it and saying that they've had great results with Ivermectin with patients. At the moment, it is not regulated for use and not a license for use with human beings for COVID-19 in South Africa. The South African Health Products Regulatory Authority has not done that. I mean, is this something we need to pay more attention to? I mean, it's on every WhatsApp group I belong to, and yet our regulatory authorities, our scientists, are saying we shouldn't use it.
I think when you look at the situation during, the first wave, as the cases rise, people get high levels of frustration. They see the deaths occurring. In my own family, I'm dealing with that problem. And we feel helpless. We feel like we need to do something. And so we want a miracle cure. Please give us a miracle cure. And in the first wave, we had 2-3 miracle cures. The first of which I had to deal with was BCG. Why aren't you just giving us BCG? Because, it protects us from COVID. The second I had to deal with was hydroxychloroquine, which was even being promoted by presidents. And then the third I had to deal with was this Madagascan, artemisinin formula. And people are saying, artemisinin, why aren't we importing this from Madagascar and giving it? It's a miracle cure. Didn't you see how it's curing people in Madagascar? Well, every one of those things have been debunked. Those are not miracle cures. They are not treatments. They've all been discarded. So second wave comes, we're in the same situation. People are feeling the pressure, especially medical people. They're watching the patients that they have. They're seeing the deaths occur. They feel helpless. They need a miracle cure. And so they'll grab at anything. We can't work like that. It's, ivermectin this time, hydroxychloroquine the last time. We have to make decisions on scientific evidence. We have standards. We have a very clear way in which we make decisions about whether medications work or not. It's not secret. It's not a conspiracy. It's a standard set of information that's required. We require double-blinded clinical trials in order to assess the efficacy of a drug. That study has to be done properly. The current evidence on ivermectin, which has been reviewed many times and was reviewed by the National Essential Medicines List Committee, and they found, very simply, that the evidence is not adequate. Why? Many of the studies are just poorly done. The endpoints are not clearly described. The way in which the intervention is done is not clear what the doses are. So there's a whole range of concerns about whether those studies are even interpretable. Some of the studies that are interpretable show benefit. Some of the studies that are interpretable don't show benefit. We also have to be careful because some of those studies actually don't have a placebo. They have hydroxychloroquine in the control arm. So ivermectin could do better than hydroxychloroquine because anything can do better than hydroxychloroquine from all the harmful effects we know of hydroxychloroquine. So there are many considerations. We have to trust that our scientists and our regulatory authorities use all of that evidence and make careful decisions. And right now, we want more evidence. Thankfully, it's coming. There are several trials underway. We're expecting to get that evidence. That evidence can be collated, added to the existing body of knowledge, and then we'll be able to make that judgment. Remember that ivermectin does not kill the virus at the levels at which they are used. The amount of ivermectin that's required to kill the virus is toxic to humans. So it does not work by killing the virus. It has to work in some other way. And we don't know what that way is. We don't have a biological understanding of that. So that's another set of research that we need to do. Because this is not a drug used for viruses. It's used to treat parasites, flukes and roundworms, and it's used largely to treat animals. Right now, the only ivermectin that's licensed and legally available in this country is animal ivermectin. So you can see the complexity of the issues, but that there's a scientific method, and if we don't follow it, we open the door to people just being able to use anything. We have to ensure that it's scientifically sound.
Professor Karim, what about the fact that when we take a look at what's happening in India, in some districts in India, they're actually issuing ivermectin as part of the government care packages to ordinary citizens. And that move in and of itself has given people a lot of confidence in the drug, saying, well, if India is distributing this to their people and they've suffered so much from COVID-19, why aren't we doing it?
Yeah, by that token, in the first wave, India included hydroxychloroquine in their standard first-line regimen. They were dishing it out to their patients in the first-line regimen. In fact, hydroxychloroquine, the biggest producer of it, is India. And that led in South Africa, you may remember, to a run on hydroxychloroquine at all our pharmacies. And so those patients with lupus who needed it, we couldn't get it. So we had to import extra hydroxychloroquine from India for that purpose. So I wouldn't use India's judgment to include it in their first-line regimen based on their track record of hydroxychloroquine. We need to make sure that the scientific evidence is sound. And I'm optimistic that that evidence is becoming available.
Well, let's have a look at some more of the tweets that people have sent us, and some of them coming up on the screen now. This is from Tabangal saying, how many days does it take for a positive person, a person who tests positive for COVID-19, to stop being infectious? If I remember correctly, the guidance has actually changed in the last 6 months.
That's correct. You're absolutely correct. So initially, we were concerned that the virus was still alive as it was being expelled over a long period. We thought at that time it might be, much more than a week. But there was then several studies, and two in particular, one that was published in the New England Journal of Medicine, that looked progressively from day one of symptoms as to how long can the virus be cultured. Not PCR positive, can be cultured. In other words, that it's live. And they showed that that occurs up to 8 days from day of first symptom. So day of first symptom for up to 8 days. And when you get to day 9, day 10, virus is no longer viable. Even if the PCR is positive, it's not viable, it's not live. So that was the basis of our change from a 14-day isolation period to a 10-day isolation period, based on this 8 days when the virus is viable, and the 2 days is just there so that if there's any issue relating to when the date of first symptoms, so it's a bit of leeway, 1 or 2 days. So the 10 days became the standard, and WHO adopted it based on that evidence. So there's quite strong evidence that people who become infected for the first 7 to 8 days after they get their first symptom, they will continue putting out an infectious virus. They can still test PCR positive for several weeks, as I pointed out, but they do not have live virus. With this new variant, we've been looking at the same issue, and it looks like it has no change. It has led to no change in terms of that time period.
All right, Professor Karim, we still have a couple of tweets coming through at this hour. Here's the next one for you. Is it a must to get vaccinated because it's your life decision? That's what Mujalifa Muloisane wants to know. And perhaps I'll just add a second part to that question. When it comes to the vaccine, do you think we're going to move at all to a point where people need to have vaccination certificates to show whether or not they've been vaccinated?
So I'll answer your second question first. You will almost certainly require to have a certificate. Otherwise, you will probably not be allowed onto aeroplanes. You will not be allowed into other countries in due course. Not right now, but in due course, once vaccines become pretty much the standard. So I think that is going to be a must. And that's why, as part of the rollout, all countries have to establish some kind of electronic database, so that if somebody is getting onto a plane or wanting to confirm that they have been vaccinated, there's an electronic database to check that. So that's going to be a must. The issue relating to should vaccinations be compulsory, I'm of the opinion that vaccinations should not be compulsory. I think it's each person's right to either be vaccinated or not. That's their judgment, that's their decision. I think if we make it compulsory, it would feed the kinds of conspiracy theories that you hear. Just the nonsense about, they're trying to put microchips in us to monitor us. I don't know where they get ideas like that. But, I think we don't want to feed those kinds of conspiracy theories. People should be able to make the judgment that they want to protect themselves, their families, their work colleagues, and so want to be vaccinated. And if we may end up with a situation where if you're not vaccinated, you would pose a threat, for example, if you go to university. So they may be in due course, I'm not talking about now, so let's not confuse people about this is going to be anytime soon. I'm talking about next year or even the year after, that at some stage, people will come to realize the importance of being vaccinated, and that if you're not vaccinated, you have to take the consequences of that there will be certain things denied to those who are not willing to be vaccinated. So I'm hoping that most people will eventually agree. I just looked earlier this morning at a meeting that I had with the African Centers for Disease Control, the African CDC, where they just presented their most recent survey. They did a survey across 14 countries, and South Africa featured in there, and we had a 22% hesitancy rate. So that means 78% of our population is quite happy, and they said they would be willing to take a vaccine if it's shown to be safe and effective. So it's that 22% that makes a difference. And we hope that with campaigns and so on, the education would enable those people to make a positive decision. Even if a fraction of them do that, that's fine. We don't expect anyway to be able to vaccinate every single individual. Very few countries are ever able to do that. So we would allow, and herd immunity allows us to have a small proportion that won't be vaccinated. And for that reason, I'm a supporter of it being a voluntary decision that each person makes on their own, with one small caveat, and that is that there may be situations where vaccination is compulsory. And that may be in situations of high risk of super spreading events. If we, for example, have an outbreak in a facility, there may be a need to go in there and vaccinate every person to protect and to prevent that outbreak from impacting the whole country. For example, in those situations, the National Health Act enables that. There are provisions in the Act in that kind of situation, because that's a dire emergency where vaccination needs to be compulsory. But other than that, I think it should be voluntary.
Professor Salim Abdool Karim, Chair of the Ministerial Advisory Committee on COVID-19, we really appreciate the time here on The Pulse. Thank you very much indeed for being with us over the last half an hour.
Absolutely, always insightful.